that varies in degrees depending on what happened and who was involved. Ladies and gentlemen, by discussing pain and pain management, Africa Online hopes to raise awareness on a topic we live with every day, but very often never really know how to deal with it. Before we drill down into the nooks and crannies of the subject this afternoon, here is senior staff correspondent on the other side of Maryland with what's cooking in his editorial kitchen. Asonglefac Nkemleke, over to you.
Thank you so much, Divine, and welcome to the program, everyone. I hope that I'm being received 5 on 5. That said, let us get going. September, ending tomorrow, is often associated with fire because it was the month of the Roman god Vulcan. Forgers, those who work on iron, are also known to be interested in this day in the month of September. However, today is Confucius Day. If you come from China, Confucius, you should know him better. So try your luck, because Confucius is associated with charms and things to get your luck. And of course, today again at sundown, it's going to be the beginning of Rosh Hashanah. Oh, Divine was talking about pain. Yes, pain. Oh, yes. A pleasant or disturbing experience. Oh, pain. What? A sensation, a feeling? Or is it just usually sharp or dull? Does it really happen every day or every second, or does it never really happen? How do you measure pain? How do we manage it? But above all, what is pain? Or is it just to singer Angelina Jolie, quote, without pain, there would be no suffering. Without suffering, we would never learn from our mistakes. To make it right, pain and suffering is the key to all windows. Without it, there is no way of life. Angelina Jolie. Well, that's her take. What about Jim Rohn? Jim Rohn, on his part, says, we must all suffer from one or two pains, the pain of discipline or the pain of regret. The difference, according to Jim Rohn, is discipline, which weighs ounces, while regret weighs tons. So cycling champion Lance Armstrong, we all remember him, I believe, thinks that, quote, pain is temporary. It may last a minute or an hour or a day or a year, but eventually, that is, it will subside and something else will take its place. If I quit, referring to himself, Lance Armstrong, however, if I quit, it lasts forever. So quitting in whatever circumstances when you are facing pain does not solve the problem. So quitting in whatever we do and from whatever we sustain may never be the option. And of course, we referred also to the dictionary. The Merriam-Webster's Deluxe Dictionary tells us that pain is, quote, usually localized physical suffering associated with bodily disorder. It continues, it is also an acute mental or emotional distress or suffering, end of that quote. But Medline Plus, that trusted health information for you internet site, tells us that there are two types of pain, acute pain and chronic pain, where acute pain usually comes on suddenly because of a disease, injury, or inflammation. And acute pain can, according to that dictionary, it can often be diagnosed and treated and can go away with the treatment. Chronic pain, on the other hand, lasts for a long time and can cause severe problems, end of quote. But above all and beyond definitions, pain is something we live with every day, yet tend more often than not to ignore. You prick your finger, as Divine mentioned, you feel pain. Someone utters an annoying word, you are not just hurt, you feel pain. You lose a loved one or someone you admired, you feel pain. One of the worst moments of unbearable pain is when one undergoes a break, or rather a breakup in one's relationships, especially if such a relationship had been very close, very intimate, and apparently very sincere. This is the pain that is both psychological and emotional. and some of the pain leads to disastrous consequences. A remedy to disastrous consequences when we suffer pain can be our ability to manage that pain. So a prick by a needle gradually fades away and we forget about it or totally, or a cut or wound sustained in the process of either working in the kitchen, slicing those tomatoes or slicing those onions or whatever, doing chores lasts, the pain sustained from there lasts a very long time. And you may, of course, need Band-Aid to hold back the blood. But treatment of or taking some pain relief tablet is what you resort to when you feel that pain. A headache, a stomach ache, well, it's all pain. But a psychological and emotional pain may last longer because the vacuum created by the departure of one or other person in your life, that significant other, may cause a long-term pain, pain that remains with you for years. And pain leads to shedding tears more often than not because of the excruciating pain itself, but because of the emptiness we must navigate through. We will conclude this reflection with these words from Mary Tyler Moore. Know her? Well, you can Google and you'll find her. You can't, that is what she says. Well, pain nourishes courage. You can't be brave if you've only had wonderful things happen to you. Those are the words of Mary Tyler Moore. Do you agree with her point of view? Does pain spur you on to move on and do and achieve that goal? Or does pain scare you into your shell like a tortoise or a snail? Let us hear from you as we leave open the discussion door. What is pain? How do we manage pain? So please, over to you. I know Reverend Pam is streaming this, and I know we will have answers from our various contributors on this September the 27th. Oh, is it 28th? Yes, it is the 29th. It's the 29th, actually, because tomorrow is the 30th. And indeed, the month of September is going away. But in Maryland, they tell us it is going to be 97 degrees hot. So we are not there yet, but we have hope, and we do not expect to suffer from any pain because of the heat. So, Reverend Pam, are you sustaining your pain? Are you feeling the pain of that rain in Houston, or the flooding? Is it causing you any pain? Let's get started. Over to you.
Thank you, Niason. Can you hear me?
I hear you 100% over 100%.
Okay, yeah, I think it's streaming on Facebook. I have decided to live a pain-free life. So we have Dr. Ogoji and Dr. Tazong on the line. Let's give them the airways, okay?
Yes, please. Who's going first? Let them.
Dr. Ogoji is at the airport. So.
Oh, wow. I hope he's not flying to Nigeria.
Dr. Ogoji,
we're going to miss him.
The airways are yours. Dr. Ogoji? Okay, Dr. Tazong. I don't know, Dr. Ogoji.
Hello?
Yes, Dr. Tazong, welcome.
Oh, we lost Dr. Ogoji. I think he's probably going through security. Dr. Tazong.
Thank you so much. All right, let me put on my earpieces.
Sure. Take your time. Yes, we are discussing pain and pain management, personal experience, and then, of course, go into the subject.
You know, no matter how hard it gets, I've decided to live a pain-free life.
That's great. That's great. Yes, it's absolutely, it's necessary to do that. Ignore everything.
After my last surgery, I made up my mind that, I'll live a pain-free life.
Yes, that's good. I always try to tell friends and relatives and whoever is near me and talks about pain, ignore it, take a deep breath, take a sip of water, and just move on. Because if we don't move on, it will haunt us forever. We don't want that to happen.
Well, it depends on the type of pain. There are some pains that you cannot ignore,
I know. But eventually, though, we must try to ignore, because if you lose a loved one, you lost your mother at a tender, or your dad at a tender age, you let go as you grew up. It happens to all of us. My dad passed in 1983. I moved on after. And those are the things that when you lose a dear one, a loved one, you feel that pain. But if you let it continue, you will be defeating all purposes of life. Reverend Pam.
While we're waiting for Dr. Tazo, mine passed away December the 1st, and if I did not know Jesus, I would not have survived, So I praised my way, and I decided to spend my time after being devastated.
Yes.
I spend my time thanking God for blessing me with such a wonderful father, wonderful parent, So
yes.
Oh, okay. Our doctor from Senegal is in, and Kong, we can hear you. That's Dr. Kumba. Dr.
Okay.
She's calling from abroad. Can we give her the airways?
Sure.
Absolutely. Let's do that.
Okay, Nia Song, introduce yourself. That's Dr. Kumba, Dr. Vivian Kumba. Kong, can you hear us?
Okay. Dr. Vivian Kumba Alaka. I know she may not get that from
her audio
here because...
is not on. Her audio is not
okay.
on.
Audio not on. Okay.
Okay.
So I hope she will eventually come on, and we will talk a little Bangwa and then some Bali, and we can move on with the other languages. Of course, English is the main language of this broadcast.
Yeah. Okay. Go ahead with your with Dr. Tazo.
Okay, Dr. Tazon, you get going, and we'll get we'll get Ms. Kumba on later on. Go ahead, Dr. Tazon.
All right. Good afternoon, Nia Asong and Reverend Pam. Thank you again for always taking the lead and just bringing up topics that really appeal to people and that are affecting many people. I think pain is just one of those things that a lot of people have to deal with on a daily basis, or just about everybody's going to deal with at some point in their lives. And it's a very wide-ranging topic. I don't know that we can do it full justice in this show, but we will do the best we can to discuss a few things that pertain to pain.
Yes, we'll do our best.
What exactly is pain?
You tell us.
So,
yes.
Pain, the most common thing we think about when we think of pain is the physical response you get when something happens or you touch something. You touch something really hot. If your body is working right, there's an immediate sensation that your body picks up that sensation and it takes it to your brain, and your brain sends a message back saying, this hurts. Take your hand off. And so pain is a necessary part of living. It protects us. But sometimes it will become a nightmare for us if we don't address it, or if we don't understand it or address it properly. And then I know you were talking about pain. Acute pain is a pain that you feel, like you said, something happens to you, and in a space of about 2 up to 3 months, you have the pain. It's considered to be acute. Chronic pain is pain that lasts longer than 3 to 6 months. At that point, you're dealing with something that is tormenting you, because when it's acute, usually you can find the cause, you can address it, and hopefully it goes away. Chronic pain becomes a different thing. And the way I think about it, it's about, I just remember when we used to have patients in the intensive care unit. And when they first came in, you would check them. We always had to draw blood on those patients. And they were pretty nice about it. After about a week or two, those patients became angry, because now the pain that they're feeling is not just you sticking them, everything becomes painful. Everything bothers them. And that's how chronic pain is. Once you move from acute to chronic pain, you start changing the wiring in your brain. And so your brain starts firing a lot of different pieces of information and telling you that there's pain, even in places where there's no pain. So somebody may have had a cut on their leg, and after struggling with pain for a while, pretty soon everything begins to hurt. You touch them, it hurts. Every single thing, they're very sensitive. And then we have other kinds of pain. There's a pain. So this is the other thing. If you think about why we have pain, it's something that is supposed to be protective. So if you sit around and you hurt yourself, your body gets a message and it sends it back to you and says, listen, there's pain here, protect that part of the body. Now, our internal organs don't always come into contact with a lot of injuries. So they don't have as many wiring nerves to send information. And that's why when you have pain in a lot of your internal organs, you can't quite tell where it is, or sometimes it's referred to another place, for example, a heart attack and so on. The pain goes somewhere else. So it's because the wiring for the internal organs is different. That's what they call visceral pain. It's dull. It's not very clear. You know something is hurting, but you can't quite tell what it is. And you can't quite put your finger on where it hurts. Whereas if you cut your leg somewhere, you can feel the pain right where you cut it. You can point to it. You can describe exactly what the pain is. It's not like that with most of your internal organs. And so, if you think about it, it's nature's way of adapting. Most of the pain we experience is pain that comes from outside, and it's because of our direct contact with the environment. Your internal organs do not have that kind of direct contact unless in very special circumstances. And then, of course, we have other kinds of pains. For example, if there's some kind of damage to your nerves, or there's anything that distorts the wiring of the pain sensation in your body, you start feeling different kinds of pains. For example, with fibromyalgia, with what we also call allodynia, where your body becomes extremely sensitive. You don't really have any injury, but you touch somebody somewhere or they put on clothes and it hurts. So there's such a wide range of what pain is that even when we have patients that have pain, it's really difficult for us to assess them because you're trying to be fair with the patient. And we also know that there are people that exaggerate what is going on with them. But because pain is so subjective, it's hard to say something negative about somebody experiencing pain. Now, sometimes we know that certain kinds of injuries or certain kinds of illnesses produce certain levels of pain. For example, we know that if somebody has a kidney stone, it is very painful. We know if a woman is having a baby, it is very, very painful. We know that. But when you talk about other things, maybe somebody had an injury years ago and they keep having pain, the struggle always is, are they really having pain? Or is it now all the other messed up pain pathways that they're experiencing? Or are they just exaggerating the pain because for some kind of benefit? For example, they need more medication to, because a lot of the pain medications that we use nowadays tend to, affect other parts of your body, like your brain wiring for pleasure and so on. So you always wonder, is this patient really having pain, or is there something else going on that, that is beyond medical experience? And that, I think that's what makes pain such a sensitive topic. And I also think, looking at the picture today, we had, once upon a time, they used to say pain was one of the vital signs. If you treated your patient and you didn't treat their pain well, all of a sudden you were not practicing properly. And then people started dying of opioid overdose. And now they tell us, well, you can't really be giving them that much medication. And so it's a struggle for us because a lot of our patients come in, people that have been on pain medication for a long time, and some of them absolutely need it. Some of them don't really need it, but you can't quite differentiate. Sometimes you try, but you can't quite differentiate. And it is a struggle for us taking care of these people because you want to be fair and just with your patients, but you also have to follow the rules of the law while trying to satisfy your patient's needs.
Yes, Dr. Tazon, take a breath and we'll try to see if we can get back to Dr. Kumba in Dakar, Senegal. She's gone. Okay, Dr. Tazon. Yeah, she's on. Okay. Dr. Kumba, good afternoon or good night, good evening, wherever you are. I know your time zone is different than ours. Welcome on board.
Thank you, sir. Good evening.
Yes, this is Asonglefac and Nkemleke, Alaka.
Yes.
So thank you very much for coming.
Just calm down. I won't take it for too long. I'm at 8:20 p.m. in Dakar.
Okay.
So it's good evening for me. And
Amazing.
Since you're afternoon, I say good afternoon to you.
And we say good evening to you.
Thank you.
Yes, so we're talking about pain. What do you know about pain? What are you going to share with us? Please, since you are calling from abroad, we want you to take all the time you can, then we will take over after you.
Thank you very much for the time. And I want to thank Pamela for inviting me on this. You see, by my profession, I'm a medical doctor, a general practitioner for over 20 years. When you talk about pain, it rings a good bell in my head because the doctor's nightmare is pain. The nightmare of any practitioner is called pain. And like you have put it in your introductory message that I saw, pain can be from an emotional standpoint, but also from a physical standpoint. Now, the emotional pain is a very important issue because in practice, for example, for a medical doctor, it is not easy to decipher emotional pain in a patient. And this emotional pain, just like you put in your own introduction, is from a happening. Somebody gets hurt and feels really bad. And I must say that in practice, this is easily missed because when a patient is talking to the doctor, the patient will come with every other complaint. You know, doctor, I cannot sleep well at night. Doctor, I have headaches. Doctor, I might feel my heart beating. That's to say they have palpitations. But the real thing is that there is a hurt somewhere. And that hurt is producing a pain which presents as a myriad of other things besides what is commonly known as pain. In which case, if the doctor is able to question the patient a little further, as one has been able to experience, you are able to put a finger on an emotional stress that is producing all the other myriad of problems. Blood pressure is high, the patient is feeling all kinds of things, but does not notice that it is from that emotional setting. I give you a classical example or a typical example. You have this couple that cannot have children. We are in Africa, I'm in Africa, my setting is Africa. And in Africa, children in marriage is a very big thing. So you receive this woman in the consultation room and she starts saying, doctor, I have not been sleeping very well. Doctor, I feel a bit of discomfort in my abdomen. My stomach feels uncomfortable. It doesn't feel, it's like it's standing. You know, they say in Africa, it's standing. I don't stool, I don't. And then you get asking questions and you just ask one very salient question. Madam, how many children do you have? A typical response to that is tears in her eyes. Then you see her pain, the tears. And the question is, why do you have tears in your eyes? I just asked how many children you have. Why do you have tears in your eyes? Then you start hearing, doctor, I've been 5 years married. I've been 8 years married. I've been 10 years married. I don't have a child. Then you know her pain. So pain is a very, very deep thing for many people in that sense, because a lot of things will go wrong just because in her emotions, she is disturbed. She cannot bear a child for her husband. It has a whole set of consequences for her person, for her family life, for her extended in-laws and everybody. And so she bears a deep-seated stress and strain, which now presents as a number of things. But this is a typical type of emotional pain. Sorry. And incidentally, for us in Africa, unfortunately,
I'm sorry, that covered it.
Are we
please,
on?
Yes, somebody seems to be having a home conversation. If you are conversing, please mute your phone and then you can unmute later on. Dr. Kumba, go ahead.
Thank you, sir. I was saying that in the sense of that kind of pain I've been describing, it's an emotional pain and it has a lot of psychological and psychiatric consequences. And unfortunately, we work here in a setting where mental health is a very big issue. There are a lot of deficiencies in mental health in our setting because in that kind of situation, this is a typical situation of mental health. And it befalls on a general practitioner, maybe even the gynecologist who will receive this woman, every other specialized doctor except a psychiatrist, because psychiatrists are not very common around here, who will now have to handle that pain. So we find ourselves counseling these people, talking to them, trying to talk them out of the pain, even trying to use their cultural aspects of their lives and their religious aspects of their lives to bring them out of this kind of emotional pain. That said, I want to talk a little about the typical kind of pain that when you just say pain, every common person knows that, oh, when I hit my toe, your introductory message talked about hitting the toe. When I have a physical impact with something that is not comfortable, I feel a pain. The person who was talking just as I was signing in was talking about visceral pain. You know, the pain that the patient will actually come and tell the doctor, I feel a pain. Doctor, my toe is paining. My head, I have pains in my back. I have pains in my abdomen. That kind of pain is a typical symptom in practice, in medical practice. And it can be from a lot of things. But I would want to talk about that pain in terms of the different types that can be. We talk about pain as a symptom, just an acute pain, for example, which is a few hours to a few days old, which means, doctor, I have pain for 1 week now. It's not up to 2 weeks I've been having pain. So it means that this pain is probably an acute situation. Then we need to talk to the patient and get to the root of the cause of that pain. Because until you get the cause of that pain, the pain cannot be handled. You need to handle the cause. And so what would be the causes of acute pain? A lot of things can cause acute pain. And one of the causes is trauma, which means, like we were talking about, hitting the toe, having a cut, a road traffic accident, somebody has impact with parts of a car or hard road surfaces in a road traffic accident, then there will be a lot of pain, very deep pain. And you hear the patient even groaning and screaming in pain. Now, the other kind of pain I want to talk about is chronic pain. The person who was talking, as I say, was talking also about chronic pain. When pain stays and starts getting into several weeks persistently, then it turns chronic. In the setting I work in Africa, one of the reasons why pains get chronic is not just the underlying medical causes, but the manner in which the original acute pain was handled. Sometimes somebody has a pain, especially like in the case of when people come with things like back pain. Pain may be in the back and it's coming from the muscles of the back and the bones of the back, the vertebral column. If it is not properly handled, it has a tendency to gradually go into weeks and months and even years and become really chronic. And why is that? Because if the pain is present, pain is a very good signal of certain processes in place. And the doctor knows those processes. One of the biggest of the processes is what we call inflammation. If somebody has a pain, whether it be because he hit a toe, he had a road traffic accident, or there are some changes in the vertebral column that are producing muscle pain and bone pain, it is all most of the time due to inflammation. How is this pain handled? In the recent past, what I have observed in my practice, in my environment, is that there is a shift from looking at pain as coming from inflammation. Gradually, clinicians are looking at pain as coming from the nervous system. And so the basic principle of treating pain as a signal for inflammation is gradually shifting to treating pain as coming from the brain or the nerves. And so we start taking ourselves away from anti-inflammatories, and you see patients come into the hospital and doctors are prescribing medications that used to be reserved for very special situations, like those centrally acting medications. And I think that it's a very terrible shift, because if pain is treated in a basic way, very, very basic way, acute pains go away fast. I'll give you an example. A person who has a road traffic accident and is in very terrible pain, there's an acute situation there. It's possible to treat both by looking at the possible acute inflammation and the central situation. But somebody who has a pain that is not too severe, but there was also a trauma, he hit his toe, or a carpenter was dealing with wood and the wood fell on his leg, and things like that, things that we see every day, then it is not as bad as you want to give somebody something centrally acting. Therefore, you concentrate on giving the person the pain management chemicals, the pain management medications that are clearly anti-inflammatory. I'm saying this because, in my observation, if I were to be handling that pain, for instance, of the person who had hit his toe or a plank fell on his leg, I would probably be giving him ibuprofen. I will not be giving him Traba, for example. I think there are pharmacists on this forum hearing what I'm saying. Because if you give ibuprofen, you are doing an anti-inflammatory process suppression. When you give Traba, I don't know how much Traba suppresses inflammation. Then you find this patient who will linger with pain because he came in, the first thing he was given was a traba injection or something. Then it lingers into days when it could have stopped in 24 hours or 48 hours. And so pain management in the hospital, especially amongst clinicians and their associates in the hospital, is a very big issue for me, and I have seen it in and around us. It is a very big problem. The other kind of pain that I want to talk about a little again is the visceral pain that I heard somebody mentioning already. Now, when there is, as I'm saying, pain is typically a representation of the presence of inflammation. When there are problems in the internal organs, somebody has a kidney stone, somebody has an inflamed appendix, somebody has a gallbladder stone, you know, any of those type of things will produce a visceral pain, a pain which is because there's inflammation inside the abdomen with one of the organs. If there is myocardial infarction, then pain is coming from the heart and things like that. There's a way those pains present. And when those pains present, if the doctor is able to, or the clinician, whoever it is, the staff nurse, whoever is on duty receiving that person, is able to interview the patient properly, it's possible to take it in a particular direction, because the good thing about the nature is that Mother Nature has been very wise. In that, I want to say that God is full of wisdom. Why? Because all these pains we are talking about have their characteristics. They have their characteristics which can easily narrow down what you're doing, trying to identify. So if you hear somebody say, I have pain in my abdomen, the questions you ask will take you from a myriad of causes to one or two causes, which means you are narrowing down so that you can get to the root cause of that pain and handle it. But when we are feeling overloaded by work, as we have been feeling recently, as I observe around me recently, then we don't do the right interview with the patient. We rush it. The patient says, I have pain in my stomach. This side has been paining. Oh, go and do an echography. Let's see whether you have a stone in your kidney. You don't even know where the pain is coming from, the end of the kidney, or you have not characterized it by questioning to bring it down to the source. Because when you characterize it well, it is you narrow down all the other possible things.
Yes.
And bring problems which become easier.
Okay, Dr. Kumba,
Yes.
just so that you take a breath, Dr. Kumba, Reverend Pam has a question for you. So while you take a breath, she'll be asking her question, just so you take a breath, because we don't want you to suffocate because of not having a breath. So Reverend Pam, yeah, I know you have a question there.
Yeah, just so you know, she won't suffocate. She's an option. And
I'm a teacher's daughter.
A teacher's daughter, that's fine. And she grew up in Fontem with all the hills, so she will not suffocate. But I just wanted to, before I ask my question, I just wanted to introduce Dr. Kumba to Dr. Tazon. Dr. Kumba, the person who was speaking before you came, is one of our faithful medical squad members, Dr. Tazon. Dr. Tazon, meet Dr. Kumba. Dr. Tazon, I think your audio is muted. Dr. Tazon.
Hello, good afternoon, Dr. Kumba. I was just listening to you.
Good afternoon, Dr. Tazon. How do you do?
I am wonderful. Yourself?
Blessed and happy.
There you go. There you go.
It's amazing.
I like that.
Dr. Kumba, I'm going to look for a flight. I'm coming to Dakar. You know, I need to get out of this country for a few minutes.
You better come and tap some of the blessings and the joy around here.
I am coming.
Amen to that.
Okay. Question for you.
Dr. Tazon, you and I are left out.
No, they are not. You're
not left out. You have a choice.
Don't start any war here. Don't start any pain. Don't start any pain.
Yeah. Okay.
Exactly.
No pain.
Pain-free show. Okay. Dr. Kumba. You know, our women, you know, in your practice on the continent, I'm sure you've seen this. Yeah, you continue to see this fibrotic pain. I suffered from fibroids. A lot of African women do. I suffered for so many years, had 3 surgeries. The pains were so unbearable, you know, because when you have the surgery, they will tell you it can come back in 3 years. If I know now what I knew then, I would have removed my organs during the first time in 1991. but I kept keeping my organs because culturally, our women feel like, oh, you know, they have to keep all their organs that they came into this world with. It doesn't matter whether the organs are afflicted or not. But in your experience, you know, because there's no point suffering. Again, I had 3 surgeries. The first one was in 91, second one was in 98, and the last one was in 2010. Okay, why did I go through all that? I wanted to, and I ended up having to get rid of the organs because of the pain. The pains were unbearable. They were so unbearable that there were several days I could not get out of bed. And then the days I could get out of bed, I would get Kilorolac shots just to be able to even function. You know, my question to you is that how rampant is it in your practice, and how reluctant are the women on the continent to the idea of having a hysterectomy, you know, or myomectomy? Because the thing is that's if they can even find a hospital that has the competency and the safety in place. Dr. Kumba.
Yeah, talking about uterine pain and possibilities of myomectomy or hysterectomy. I want to say that in practice, even in medical principles, what you went through is a typical situation, because in principle, women of reproductive age, hysterectomy is not on the table until nothing else can be done.
Yes.
Principle. And as you have rightly said, on the African continent, it is almost taboo to touch the reproductive organs of a woman. It's almost taboo. So we won't be talking about a hysterectomy quickly. We won't be talking about touching any organ in the woman quickly. But once again, I come back to the issue of evaluation of pain. Now, fibroids have different levels that they produce pain. So if we see a patient, the good approach is to evaluate the patient's symptoms. Ideally, fibroids do not produce pain easily, ideally. So when fibroids start producing pain, then it has advanced from a very simple fibroid to calcified or some other kinds of fibroids, which means that should be considered. The other reason why fibroids may cause pain may be related to the size. It doesn't make any sense, the size and the position in the uterus. It doesn't make any sense to do a myomectomy for a huge calcified or degenerated fibroid when it is better to just take out the uterus. The women are reluctant, yes, but in practice, ethics allows the doctor to educate this woman on her condition so that she is not taking an ignorant consent, she's taking an informed consent. When women are reluctant, part of it is ignorance. They don't know what is on the table. They don't know what's at stake for them. The question is, would you rather try to have children or and live in pain and try to have children, or live pain-free? So it is good to educate these women, and in practices where they are properly educated, the scenario is a little different. Reverend Pam, I would be asking you to think back to 1991 and find out in your mind, when you had the first surgery, how much education about your condition did you receive?
Not much.
This is very important, because in practice, there's what we call informed consent. For every surgery, not even just for fibroid, for everything you do for the patient is supposed to listen to the practitioner, give them education about the situation. Okay, you have this. These are the options on the table. These are the consequences. These are the consequences. These are the possibilities. What do you think is better for you? We discuss that so that the patient is taking an informed consent. One of the reasons why pain is poorly managed and issues of pain are poorly managed is the absence of the education of the patient by the practitioner.
That's right.
It's a very important issue. And in fact, last week, almost 2 weeks ago, I was in the Gambia. I had a chance to be in their clinical meeting they were running there. And the issue on the table was ethics in women in reproductive health. And you needed to hear what doctors go through and patients go through. You know, you have a colleague who just sends this patient to you. This patient has this problem. I think this is what the patient needs. I'm sending to you for this. You don't do that. Because what has the patient said about his or her condition? This woman is 30 or below. She still wants to have a child. Can you educate her as to whether there's a possibility? If it's a huge fibroid, intramural, maybe it's even in the wall of the uterus, you go and yank it out. Will that uterus carry a baby? This is the question. So it is important that the patients take an informed decision. That is the mainstay.
Just a follow-up, Dr. Kuma, thank you so much. You're right, because unlike on the continent, maybe things have changed, but here, most people are practicing fast food medicine. Dr. Tazam, you can correct me if I'm wrong, but I spent 11 years in Texas Medical Center. I mean, these people, I mean, most of the doctors, they spend like 15 minutes with the patient. A lot of them don't even have time to interview the patients or to even talk to the patients. And that's one of the reasons why I enjoy the medical missions that we've been doing since 2000. But on the continent, Hong Kong, you know, if it's okay for me to refer you with your middle name, but, you know, is it common practice for the doctors to make time spend more than 15? The reason why most of them don't spend more than 15 minutes is because of reimbursements, insurance reimbursements. That's not the issue back home. Would you say you and your colleagues actually take time to educate? I know you do, because I know you personally, but do your colleagues take the time to, first of all, listen, hear from the patients, like you were saying, you know, there might be a lot of underlying causes, emotional issues going on, and that is actually, and some of the things might be psychosomatic, you know, it might not be psychological pain, it might not be, you know, coming from a slight wound they have, or a fall that they might have. And would you say your colleagues actually take the time to listen? Because one of the things I always do when I do medical missions, both here and abroad, I tell all the nurses and pharmacists, I say, treat every patient as if they're the president of this country. I believe in patients with dignity and respect. Over to you, Dr.
Reverend Pam, I'm going to say that I'm having an echo. Is that okay? It's gone.
Go ahead. Go ahead.
I'm going to say that in terms of time spent with patients, it varies. I have found in places like Dakar, where I am now, that there is a lot of rise on the presence of insurance for health, and what you're describing as an impediment to time spending because of payments by insurance, it's setting in. But I want to talk about Cameroon, where I have spent most of my life as a doctor. Mm-hmm. In Cameroon, it is a little more commonplace to have doctors talk more to their patients. But there is still a little handicap. And the handicap is patient load. Because many doctors don't want to find themselves spending 30 minutes with a patient when there are 20 more patients on the bench outside in a big center. Mm-hmm. So the issue of patient load. And about that, I have had reason to, in some meetings where I have been part of, to really suggest that some centers set up counseling units. Mm-hmm. Because just like we deal with HIV on the continent in Cameroon, I mean, almost every center had a counseling unit for HIV. So the question is, if I don't have time as a clinician because of my patient load to talk much to the patient, why not prescribe a counseling format? And because, for instance, in most of these big centers, I worked in Nigeria, I worked in Cameroon, you will find a situation where they say, in a big center, you have a diet unit, you have those are the laboratory, so I just write on a paper, renal diet, and send to the diet unit, and the diet unit knows what to do, you know? So if I can write on a piece of paper, pre-op counseling for such and such a fibroid or such and such a condition, somebody should be able to counsel that patient, and I don't need to use precious time to do the counseling because there's patient load and every patient has a right to be attended to properly. The waiting time should not be too much because it frustrates the patients. Now, when you are looking at that scenario, you see that there is a defect because doctors have to cut down the time they spend with the patients. It's a problem. It's a very big problem. And so you are not able to counsel as much as you would have liked to. You're not able to give as much education as you would have wanted to. But there's another little thing that is cropping up, the Android age. The patient is sitting in front of you and she may be telling you, Doctor, Google was telling me this, Google told me that, Google told me that.
Yeah, that's it. That's it. Yeah.
I've had that. You know, you have a patient who comes in, you spend like 10, 15, 20 minutes to take your time and summarize for them what they need to know. And they start telling you, doctor,
Google.
This thing you said here is correct. Google told me the same thing. Or doctor, this thing you said here, I'm worried because this is the other way that Google put it.
Oh, Lord. Google doesn't have
so it is not easy for the doctors in terms of the patient load and the time they need to spend on one patient. But on the whole, there's an effort.
Can we hear from Dr. Tazong if it's the same problem here? Dr. Tazong, that same question. Dr. Kumba, thank you so much.
You're welcome.
Yeah, Dr. Tazong, one question I posed to Dr. Kumba. We have 12 minutes before we go to the top of the hour, but I mean, can you weigh in on the amount of time doctors spend with patients? And if you've had patients come to you, Google said this or WebMD said this to you, Dr. Tazong?
Well, you're absolutely right. We have a terrible problem with time with patients. And the biggest problem is that we're always in a hurry. You coined it properly. We don't have enough time to speak with patients. And the one thing that I keep trying to explain to everybody now is that, listen, for your doctor to be trusted and for you to build a relationship with your doctor, for you to be able to believe what the doctor tells you and to listen to them, you have to trust them. And that means you have to have some kind of a good patient-doctor relationship. Unfortunately, hello?
Yes, we can hear.
Go ahead.
I hear a lot of noise in the background. I'm not sure where it's coming
Just keep going. I hope somebody can mute their phone.
Wait, let me check. I'll see who it is. I'll meet them. Let me check. Dr. Tazong, go ahead. I'm not sure.
So unfortunately, because we are always in a hurry, we don't get time to educate our patients. I think, we have an interesting setup here too, because we have a lot of immigrant patients that we take care of. And addressing the problem, as Dr. Kumba said, is not just the education part. You have to deal with the cultural part. We have an issue where, the patients there are some goals that they have to accomplish in their lives. And no matter how much education you have to give them, it doesn't really change what they want. We know that a lot of young people getting married in the African continent want to have children. And so you always have to keep that in the back of your mind. And as Dr. Kumba said, women of childbearing age, even here, we're very careful with them because having children is a human need. And we don't ever want to be guilty of taking that away from somebody unless in extreme circumstances. So when these patients come in, you have to talk to them, but you have to give them the options. And then I also think it's very important to set up some kind of family counseling session. For example, yes, the woman may have a right to decide what she wants to do with her uterus, but the husband may not find that funny. You need to bring him in to understand what is going on with the wife so that he too can realize, if I love my wife enough, I'm not going to let her die from this thing. And then if they already have children, they need to understand that, listen, thank God you have some already. If this woman is not here to take care of her children, that's going to be a problem for your family. So I think education, being culturally aware of what patients are dealing with is very important. And then the time thing, there's no way around it. I think the only thing that is beginning to happen is a shift. And I know here we're beginning to do that a lot more. A lot of doctors are beginning to do pay out of pocket, where they take their time with you and do good consultations. And then you can reserve your insurance for extreme cases or very expensive procedures. So if my patient comes in, instead of rushing through them in 15 minutes, I can take an hour and talk to them and explain things to them and answer their questions. That way, they don't even feel a need to go to Google, or I get to explain to them that, listen, Google is just putting together a bunch of information, but Google is not a thinking human being. they cannot interact. They have some information, but they don't have the level of training that your physician has. Because when we are talking to our patients, it's almost as if we have a puzzle in front of us and we have a big picture we're looking at, and we're pulling things into place and trying to look at everything that concerns this patient before communicating with them. Google doesn't do that. Google just gives you general information that it has compiled together. So as a doctor, I don't really feel intimidated by Google because I know that Google doesn't know what I know, and Google doesn't have a personal relationship with my patient. I have to deal with them on the side. But as I spend more and more time with my patients, and I get my patients to trust me and I educate them, they realize I'm better off listening to my doctor than to Google. And I've had many instances where I prove to my patient, listen, Google is way off the mark. I know, I understand what you're trying to do. You're trying to get educated, but Google is not the way to go because they're giving you bits and pieces and they don't have the big picture. They don't know who you are. They can't put together a picture and give you a proper diagnosis. So I don't know if I answered your question, but I think that's what practice looks like from our side of the world right now.
Yes, thank you very much, Dr. Tazan and Dr. Kumba. Just stay on with us. This is Africa Online. We're discussing pain and pain management. I think Dr. Goji is available now. Dr. Goji, if you are with us now, come in and share your knowledge about pain and pain management. Dr. Goji?
No, he's at the airport. He just left.
He just left. Oh, okay. All right, then we will continue. From my end, I was going to ask our two doctors on the line right now about what we call nerves, because I know the human body is full of nerves. What is the role of these nerves? What do these nerves play in transmitting pain from one area to the other, or from, how does it work really? How do the nerves, what role do nerves play in this pain discussion we're having? Enough, you can go ahead first.
All right, I'll go. So I would say that your nerves are just like the electrical wiring in your house. If you don't have electrical wiring, you can't turn the lights on and off in your house. That's what nerves literally do. They carry information from your organs, both internal and external, and they take it to your brain to communicate that there's pain. And then your brain sends that information back to you to act upon what it's learned. So that's really what nerves are. It's wiring in your body that communicates. It carries information back and forth from the organ of origin to your brain, and then takes information from your brain back to your body to get things to move or to change depending on how the information was communicated.
Dr. Kumba, you have anything to add on that? If not, I have another question.
Yeah, just to say that that is why if, for instance, somebody hurts a toe, the information quickly runs to the brain and the brain can say, oh, my toe is hurt. And then there is a report which now says, what do I do next? And something is done. Now, in that sense, there is something called phantom pain. Because since nerves transmit the information, people can lose a limb. Somebody can lose a limb, for example, lose maybe even a toe or a whole leg, have a below-knee amputation, and then come to the doctor and say, I have pain in my toe. This person has a below-knee amputation of the left limb, of the left lower limb. His leg is no longer there. The left leg is no longer there. Then he comes to the doctor and says, doctor, I have pain in my left toe. That is because in the process of putting in place the nervous system, Mother Nature made it in a way that the brain has a map of the body in terms of the nerves, the information they receive from the nerves. So even though the toe is gone by the amputation of the leg, the position of the toe in the brain is still there. And so if for any reason, any other nerve that goes from around the knee, which has any closeness to what would have come from the toe, sends any signal to the brain may receive it as pain in the toe. And it's called phantom pain. And it is commonest in soldiers because they are the ones who get, in fact, it's in them it was first identified. And it's a very big nightmare for the doctor because you have this patient who has no leg. He has pain in the toe of that leg. How do you tell him that he has no toe, so the pain is not from his toe? Therefore, the treatment has to be tailored to suppressing something in his brain.
Yeah.
All right.
So it's important. Phantom pain. Yes.
All right.
That's the commonest pain that comes from nerves.
Okay.
Which is quite difficult for the doctor.
Yeah, we're going to tilt the conversation a bit because we're getting to the top of the hour. But before we do so, this other question, we have had a lot said about the female structure. What about males? how do males identify pain? Because does a hernia in a man or maybe a sexual dysfunction in a man, does that lead to pain? If so, how?
Well, when we talked about the woman, is because the Reverend used herself as an example to give us a question.
I know.
It doesn't mean that. Maybe if you were giving us a question about your an experience, it will help us explain it better. But don't worry, we'll just.
Careful, we are streaming live. Be careful what you say about yourself.
Yes.
In the male,
Unfortunately, I have no personal thing to tell
You're
about
blessed.
pain.
Yes.
I'm blessed. I think I thank God for that. Yes.
Good. Yeah, but for the male, of course, the male will feel some pain. The causes of pain in the reproductive area of the man will come from, like you have just said, there could be a hernia. But hernias commonly, there are different kinds of hernias anyway. The one that will be closely related to what we are trying to talk about here in terms of your question will be an inguinal hernia. The one that goes at the sides, at the top of the thigh, like going towards the testes, from the top of the thigh going down, you know, at the side, just below between the lower abdomen and the thigh. That's the inguinal area. If there's a swelling there, it could be a hernia. Now, if it's a hernia, it will be quiet as long as it's a simple hernia. You will notice a swelling there, but never notice any pain. But if that hernia becomes what is called strangulated, which means, because if it's a hernia, it comes on and off. Sometimes the swelling is there, sometimes it's not there, because there's an organ protruding into a small crevice, a small hole, and then it can go back. It's called reducible. But if it comes out and for some reason finds itself a little too enlarged, or for some reason there's a small inflammation and tightens up the hole through which it passed, and it cannot fall back in what is called reduction, then it becomes difficult for it, because that little tightening will compromise the blood supply to the organ that has found itself outside its normal position and is in that hole. It could even be a piece of fat, it could be intestines. And then because the blood supply is compromised, there is pain, and it's called strangulation. And that is a killer. That's why people take chances. You ask, no, this thing has been here all the time. Why is it paining me now? They go and take a painkiller, across the counter drugs, and it can be a very risky thing to do. Because in that case, if a doctor receives a patient who has had a recurrent hernia and today the hernia is painful, it is theater straight to reduce it surgically. You know, that's the management of that pain. In cases of STDs for men, some men feel pain when they urinate. It may not even be a straight STD. Asonglefac, Mr. Asonglefac, you are already advanced in age. People your age sometimes.
I know. Go ahead. Yes, go ahead.
My senior brother, I have an idea of his age. So,
I know. Yes.
People your age and about may have what we call an enlarged prostate. The prostate is an organ which surrounds the pipe through which the man urinates. If that happens, it can produce, there's a kind of pain it can produce. One of them is the pain of urinary retention, because if that gets large enough, then the pipe is narrowed and there is always a backflow of urine. There is a certain residual volume that doesn't come out all the time. Then there's a build up. And then the man starts feeling lower abdominal pain. But here where his problem is, in his pipe, then you are feeling it in the abdomen. It comes to say, my lower abdomen, I feel a lot of pain, especially when I urinate in my lower abdomen, you know? So it's not as if those things are absent in men. They are there.
Okay, Dr. Kumba, hold that thought. Dr. Tazan, hold.
I'm going to throw in something real quick, because it is
I was
really
going to
important.
call Reverend Pam, but okay. Yeah, Dr. Tazan, go ahead. We'll come back
There
on the topic anyway.
You asked about the men's parts. I mean, Dr. Kumba really explained that stuff good. And then there are two other things that men should be aware of that are emergencies. A lot of times when men have pain down there, usually it's a big deal. So one of them is what we call Priyapism, where you have and basically an erection that will not go down. So it could be a blood clot in one of the veins leading into the man's penis. And if he has an erection that wouldn't go down, that is a medical emergency. And recently, we had an unfortunate case where a young boy had his penis cut because he had that situation and there was nothing they could do about it. And then we have another situation that is also an emergency. It's called testicular torsion, where the testicles twist around a little bit and it compromises, again, blood flow. It could cause a lot of harm, and that is a medical emergency. So for men, when they start having issues downstairs, it's a very big deal. And one of the things that we have to know about men is that men are very sensitive about that part of their body. They don't want to talk about it. But if the pain is bad enough, they will open their mouths and speak. If there's pain enough, they would speak up. But also, as women, if we are aware that our husbands or brothers have issues down there, we need to push them to go see their doctor because those things can literally kill them. So I just
okay, my both doctors, please hold on to those thoughts. We'll come back to them. Reverend Pam has to make this announcement. We usually do it at exactly top of the hour, but I think it's like 2 minutes past the top of the hour. Reverend Pam, please, what are we discussing next week? What is the news from Houston?
Yeah, I thank you so much. I'm actually looking at Facebook. Dr. Najila Nukuna joined us. Again, I was just trying this last week, and I'm glad, Anyway, before I make the announcement, I just want to say we need some volunteers. We need IT volunteers, please. I should not be the one streaming this thing. Please, please, please. And yeah, so I'm so proud of you for finally getting your video on. I am so proud of you. We are in the digital age, So everybody else, you are no longer, I don't want to call his name because it's a
yes. As Dr. Kumba said, it's not the internet is not my age thing, so that's the problem. So go ahead now with your announcement.
Yeah, okay. Yes, starting tomorrow, we're going to be talking about domestic violence. This is a very hot topic. Actually, I think we're probably going to do this before to it. We're going to talk about domestic violence with women as the victims, and then we're going to turn around the following week and talk about men and children. Because believe it or not, there are men that are victims of domestic violence. So there are some women that beat the living daylights out of their husbands, and the men are too shy or embarrassed to cry for help. So we'll start with domestic violence. That was actually the first show we had. No, the second show, domestic violence. That was the second show we ever tackled on this show, the second topic. So domestic violence is very prevalent, not just in Africa, even in abroad, in the diaspora. The only thing with the diaspora is that, especially in the US, there's 911. So men think twice before they lay their hands on a woman, and vice versa. But in Africa, a lot of women get the serious beatings. When we were growing up, we had that some women from certain tribes in Cameroon. I'm not going to say the tribes, but I'm sure those of you who have lived in Cameroon or from Cameroon, you know what I'm talking about. They love it when their husbands beat them up because they enjoy the makeup session. To me, that's no human being can lay their hands on me. The only human being that had the right to do that was my dad, and he never did. So nobody can even try it. And I want to tell all our sisters out there, don't let any man, I don't care if the man is giving you gold and silver, you're not his property. If it happens the first time, it's going to happen again. And it's going to keep happening until you die. We've had a lot of incidences of Cameroonians, Africans being killed by African spouses. It started like a little slap. Then the next thing you know, somebody got stabbed or somebody got shot. It's been in the news. So it is not acceptable. Again, I'm not asking anybody to divorce. I'm a servant of God. The only time God allows divorce is the case of adultery. But nobody better lay their hands on any of my loved ones, because believe me, they won't get a second opportunity to do that. It is not acceptable. It is not acceptable, period. If you want to hit something, hit yourself. Don't hit somebody else's child. And then I also like to talk about the book, Africa's Brain Power. Again, written by the best in the business, a journalistic icon, like I like to refer to him, Mr. Asonglefac Nkemleke. It's called Africa's Brain Power. I had the privilege of doing the foreword and editing the book. It's a beautiful book. It's very comforting, very informative, very enlightening, very empowering. I will encourage everybody to get it. It's on Amazon. Africa's Brain Power. That's actually it's on our Facebook page, Africa Online Facebook page. So the book is there. You know, so I want to encourage everybody. So Nia Song, I'm gonna leave you back to our doctors. Again, one more plea for IT help. I see Dr. Najila Nukuna is on, but I'm trying to figure out how to invite her, you know, to post some questions. When I do regular streaming, I am able to do that, but this one I'm streaming through Zoom. So I guess I'll figure it out, you know. Back
Okay.
to Nia Song.
Thank you very much. Our two doctors who were here from the beginning, Dr. Kumba from Dakar, Senegal, and Dr. Tazan, I know she's somewhere in the United States, all the same. Let's continue that line of thinking. How concerned should the man be or should the woman be when things are happening downstairs and they don't just believe that what they're feeling is what is actually happening? How concerned should they
what
be?
is downstairs? This show is for our viewers. Let the person working in the village know what you mean by downstairs.
Well, I mean in your private parts, so to speak, the man's private parts and the woman's private parts. If something is aching down there or paining down there, how concerned should we be?
Pain in the private part is a huge thing because there are, I mean, both men and women, there are a myriad of reasons why there could be just, well, I just got interference, so I'm going to mute myself. Right?
Yes,
I mean,
okay.
Yeah, I'm sorry, I just have to mute for a few minutes.
Okay, thank you. Dr. Tazan?
Yes, sir.
Dr. Tazan,
Hello?
your audio is not, oh, okay, yeah, Dr. Tazan, go ahead, yeah.
Yes, I'm right here. Yeah, no, I think pain in every part of the body is something that you should be concerned about because it is God's way of warning you that something is wrong. Now, again, other parts like your fingers and toes and so on, you can see if you cut something, but the private parts are kind of protected. So when you have pain there, it's usually not from direct injury unless you were assaulted. It's usually not from direct injury. It means there's something serious going on. And what I would always like to express very strongly to my patients is that you need to go get yourself checked out. I know Dr. Kumba talked about STDs. There are some STDs that are very painful if you have them down there. For example, herpes. If you have herpes and you have an outbreak, herpes is known to be very painful when it is flaring. So that's one thing that, you know, again, you probably would not be able to treat at home. You're better off going to see a doctor. And then we talked about all the other things that should be concerning. We also have, especially in women, we have things like scar tissue from childbirth and so on that can cause pain down there. We have, if somebody has been assaulted before and they've damaged a lot of the organs down there, they tend to have recurrent pain in their private parts. And those are things that, again, if the woman already knows she's experienced that, then the goal is pain management. If it's something that is new and there's no clear cause, you should get yourself evaluated to make sure that there's nothing bad happening. And the goal of medical evaluation is to kind of see, is there something, is there an emergency that we need to treat, or is there something that we need to manage in the long term? And I really like what Dr. Kumba said, because I think medicine, even in the US, is going back in that direction, where when we have inflammatory pain, for example, you have a boil, a swelling, a cut or something, we try to treat the inflammation because that is what is causing the pain. Instead of going further out, it's almost like saying you try to kill a fly with a bazooka. That's what we do with the opioids. Somebody comes with a little bit of inflammatory pain, you give them the high shot opioids. They work well, but the problem is that it's an overkill and you've not really taken care of the inflammation.
And the after effects are worse.
Correct. So we're getting people addicted now, because the reason people like opioids is not just because it silences your pain from the nervous system, but it also causes you to be happy. It kind of makes you excited. So people that are going through different kinds of things, even chronic pain has an ability to mess with your moods. And so people take this thing almost as if something not just to help with pain, but also to help with their moods or just make them feel good. And they become addicted. So we really are walking away from that. Nowadays, there are a lot of changes in the recommendations for pain management. One of them is that when patients get surgeries now, surgeons are required to not give you medication for more than 5 to 7 days, because they find that after those number of days, the risk of you becoming addicted is significantly high. So the opioids, if they give it to you, it's for acute pain. It's really maximum 7 days. Back in the day, they'll give you for 30 days and they'll give you refills. That doesn't happen anymore. They give you a few opioids for the first few days when you have a whole lot of pain. They give you anti-inflammatories and they tell you how to take care of yourself. And as your surgery heals, your pain should also be getting better. We don't want to now get you hooked on stuff, and then when it's time to get you off, it becomes a nightmare for the patient and for the doctor. So she talked about the phantom pain. Again, that is from the brain. Those are the things that you really want to start considering treating with some kind of opioid or central nervous acting medications. And then we have the pain that is from damaged nerves, like in diabetic patients or even stroke patients after stroke and so on. Compressed nerves, those you can also treat with other medications that don't act directly on inflammation, because that's not inflammatory. That is more of a nerve misfiring, and you want to quiet down the nerves. So we have things like Neurontin and Lyrica, other names gabapentin and pregabalin, that are used for that purpose. So identifying the kind of pain that the patient has is really important, because it helps to guide the way you treat the patient. And then the other thing, when you talk to people that manage pain in the long term and that manage chronic pain patients, one of the things they try to do is they try to redirect the patient, because you'll find that most people, when they have pain issues, when the pain becomes more intense when they're sitting around doing nothing. So when you get an injury, chances are you're going to be sitting around the house doing nothing. When you're idle, you feel everything. When you stay busy and active, it distracts you. I remember I mentioned on the forum that one of the ways that we treat pain is through distraction. You want to keep patients active and productive. One, it makes them feel like their life is worth something, and it also distracts them from the constant feeling of pain. So that even if they get to feel pain, it's maybe on the weekends when they're not working or in their downtime. And that means that you need to give them significantly less treatment than people that need treatment 24 hours, 7 days a week.
Now, one quick question related to age. How much pain, or what should, let me put it this way, what should adults, that is people more than 50 years old, do when they begin to feel those pains? And what should kids do when they start feeling those pains? One of the pains I'm referring to is the backache or the shoulder pains that we feel. Many parents, I mean, I was at a meeting the other day and I have at least 2 female colleagues who said their shoulder blades were burning. So what should we do with such pains?
I think Dr. Kumba is back on.
Yes, I saw her on. Yeah, Dr. Kumba, may you go first?
Okay.
Yes, like with every other symptom, once the patient is worried, please see a doctor, because from what we have said today and what is real, no matter the cause of the pain, unless that cause is properly identified and handled, the pain will stay there. And the person who can identify and handle is your professional. So it is a big issue when people have pain and they don't get professional help. They take what we call commonly painkillers. They buy from the roadside and even end up buying poor quality things and drinking.
Counterfeit poison.
Suppress that pain. Counterfeit, to say the least. I mean, it is terrible. But when you're talking about people having things like shoulder blade pain, it's very essential to diagnose that pain carefully, because that shoulder blade pain could easily be coming from the heart. That becomes very significant. It can have other sources. The shoulder blade has muscles on them. There are nerves in there. The bone itself can be inflamed right inside the muscles, but especially if the pain is burning, and there are characteristics of that pain, that it's important to seek professional help, simply put. Because we don't want to tell people you can do this or you can do that, and then they start saying, oh, we were educated about this. No, it's very essential to seek professional help with those pains. It's very essential.
I have a question for both of our doctors, Dr. Kumba first and then Dr. Tazan. You know, my last trip to Cameroon was 2015. And prior to that, this happened when I came, no, prior to that, my previous trip was 2012 when my father passed away, when we had to take my father's body home. And when I came back, I started having some pains in my left leg, okay? The pains got so bad, they were just, I couldn't get up. So, you know, Africans are superstitious. Somebody told me that, oh, I probably marked something in Cameroon. I said, well, my dad told me that he raised us from his sweat. Nobody can do anything to us. But then there was one night I could not sleep. It was so bad, I decided to Google and bingo. Prior to that, I'd never heard of Maraja parasitica. And I know I'm not the only one with this problem. I am sure there are patients on the continent, even here, their father have that and something else. I want each of us to do this. When I Google symptoms on WebMD, it was like they just took a snapshot of my leg because it was between my left hip and my left knee on my thighs. I was having tingling, numbness, dull pain, burning. I mean, it was horrendous. And then I had put on some weight, and then I realized that when I lose weight, the pain goes away. So I want Dr. Kumba first, and then Dr. Tazon to weigh in. If come across that, or if it's a common occurrence on the continent, Dr. Kumba.
It's a common occurrence. I would just simply say, you see, as we have been talking, there's also been talk about, we're talking about the nerves, we're talking about you are now talking about a pain that is related to paresthesia, which is like nerve damage or nerve stretch or strain. These things are very common. People come, especially in their lower limbs, you know, in our setting, there is a lot of trekking, there is a lot of strain moving from one place to another. There is diabetes and hypertension is on the rise. So there is a lot of peripheral nerve pain, if I would put it that way. And we have them. But what I want to say is that the easy way out is what you heard somebody tell you. You have stepped on something. Exactly. You know, somebody will say, I went to my office. It looks like when I came back from work, this thing started. I don't know what I touched in my office today. That's how and he's talking to the doctor. I don't know what I stepped on. When I went back
it happens.
Work, started.
Yes.
You know, we don't throw that out completely, in all honesty. We don't throw that out completely, but we don't, and I repeat, we don't base what we do on that, because those are assumptions and presumptions without proper verifiable possibilities.
Yeah.
But that said, those pains, you yourself, you have just, I mean, your example is classical. You lose weight, it goes. You gain weight, it comes back. Yeah. Those are the kind of problems. Low back pain in adults, in advancing age. The pot belly develops in the man, he has low back pain. The woman has been able to bear a couple of children, she has low back pain. It's there, it is strain. The strain of weighing down on your tendons and your muscles and your nerves. The stretches that are happening because of changes in weight. All those things produce their various kinds of pains. And until you are able to put a hand on it, until you can put a finger on it and handle it correctly, you will give all painkillers. The patient starts telling you, if I may use the common expression in my community in Cameroon, doctor, that my pain don't start again.
My pain.
So I say, so you have owned it.
Exactly. Yeah, my pain.
Yes. How can you own it? So if you have owned it, how do you want it to ever go?
Exactly.
That's right. That's right.
So it's common, and those are things that produce chronicity and recurrence. You know, difficulties with putting a finger on the exact mechanism of that pain, so that you can take it away. And sometimes it can be really difficult. Yes, and that's why I started off by saying that this topic of pain rings too many bells in my head, because pain is a doctor's nightmare. Any honest doctor who has been in this thing for 20 and above years will tell you pain is a problem, because everything else boils down to pain.
Yeah.
So
but the bottom line,
Dr. Tazan,
can we identify the causes?
Wait a minute. Sorry. Dr. Tazan was trying to come in.
Yes, I'm going to kind of roll in Nia Song's question and Reverend Pam's question, because they all boil down to the same thing. And that's why I am approaching medicine from a different standpoint right now, because Dr. Kumba said it. And I'm glad when enough people say it, you realize it is a reality. one of the problems that we have in today's in today's world is the Western diet and the way we eat and treat our bodies. So what is happening is that we are having a rise in obesity. And obesity is a very expensive problem to have because it creates a lot of dysfunction in your body. And the way I explain it to people is, can you imagine taking the frame of a Mini Cooper, or let's just say a Volkswagen Beetle? You take the frame and you put the body of a large truck, let's just say a Chevy Suburban, on top of the frame of that Volkswagen Beetle, and you expect it to work well. And that is what is happening. A lot of times, aging brings its own problems because of wear and tear. But we can significantly reduce or mitigate those problems by being in good shape, staying physically active, keeping our weight under control, because you want to make sure that you're not overburdening your body frame, which is your skeletal structure. Every time you gain extra weight, like we talked about, that midsection gut, or even being very big up in your upper body, it weighs on your frame. It causes the spine to become a little bit distorted, and that means that the spine is going to be pinching on one of your nerves, and then you start having nerve pain that radiates to different parts of your body. And so keeping your weight in check is very important. Getting rid of the extra stuff that your body does not desire to carry, but that we inadvertently put on our bodies, is a problem. And then also the diets not only cause us to gain weight, but they also cause our pain to be worse. Everybody who understands the thing about diet understands that foods that are highly processed cause a lot of inflammation in the body. Whether or not you're sick, they cause inflammation. So if you already have underlying inflammation, what do those foods do? They come and pour. It's almost like adding gasoline on a fire. It just gets worse. So one of the ways of controlling pain is by controlling what you're putting in your body. Not only does it help with the weight situation, but it also helps the inflammatory situation. Being physically active also helps. It helps with the weight situation, but it also helps with pain, because when you exercise, your body produces natural endorphins, which are in the same family. They basically stimulate the same kind of receptors in your body as the opioid medication. So if you think about it, that is amazing that God has given us ways of regulating our own pain by doing certain things. So when we do those things, our body actually feels, when you go and exercise, you come back, you feel like your body is, somebody just took away a bunch of weight on your body, from your body. You feel light, everything is moving right. And that's because you're easing up your joints, but you're also releasing a lot of good things in your body, and it's keeping your body nice and happy.
Thank you, Dr. Tazon. Niasong, there's something we must address before we go. We have less than 6 minutes.
Yes, go ahead.
You're on the continent. Paracetamol or Panadol or Tylenol is a major problem on the continent. Not just with counterfeit, but the problem is people self-diagnosing and self-prescribing Tylenol for themselves or paracetamol. And they take it for anything, headache, fever, inflammation, but they don't know that it will have any anti-inflammatory effects or properties. And then they don't know what's going to happen to their liver. I don't know if in your practice on the continent, in all those 3 countries or 4, if you've come across a lot of people with liver issues or paracetamol abuse. Dr. Kumba, we have 5 minutes. You know, if you can how people self-treat and self-diagnose their pain on the continent.
Yes, rightly you say it. You have put it very correctly. People diagnose they just say, I have a pain, I want to take a painkiller. I think I mentioned it before about taking painkillers. I wouldn't be saying that I have personally put a hand on liver problems because of painkillers. But I want to say that if you talk of abuse, the abuse is abominable. I mean, it's just terrible. And the bad thing is that, or what makes it even worse is that the painkillers they are buying, what is the quality? Because where are they buying them from? So we are not even talking about abusing painkillers, but we'll maybe be talking about taking other things into your system and hoping you're taking painkillers.
Exactly.
So it's a very big issue. It is a big issue. People take these painkillers randomly. You normally want to take with a particular pattern so that you have some results clinically from the pharmacology of the medication. But no, there's no pattern. They just take. You know, I had a beer last night. I didn't want to have headache in the morning, so I took paracetamol. What is that?
Rubbish.
People just do that.
you know, and as I say, if we were able to do some research on that, we would probably be putting a hand on livers that are bad. But
Yeah.
before we go, since we are running, I think we're running to the end of it, I want to go back to your announcement and talk about domestic violence, just to say that it is not necessarily physical abuse. The psychological abuse is one of the worst causes of pain in the women, as we're talking about.
Yes.
The psychological torture in marriage. I'm a marriage counselor.
Psychological.
Psychological torture in marriage. I'm a marriage counselor. Women are suffering. I want to tell you that. The men may be suffering too, but women are suffering.
Thank you very much, Dr. Kumba. Don't go away. You have your last word. Dr. Tazan.
We'll need you next week, Dr. Tazan.
I'm happy that she brought that up because, you know, I have a friend that I spoke with and I want her to talk about domestic abuse. And my best friend died in a domestic abuse situation. And so it's a very sensitive topic for me. It's not just against women or men. There are some men that suffer too, but I want us to realize that it is a cycle. You know, the women are abused. A lot of times it starts off with the women being abused in relationships. Those women that are abused don't raise, they carry that abuse into their own, raising their own children. They abuse their children grow up abusive. And so it's a cycle that keeps on giving. People abuse, they become abusers, then they become abused. I mean, it just keeps going on and on. And we have to break that cycle. And so sometimes it's easy for us to look at the abuser like the evil one, but we also have to kind of start looking at them with compassion and saying that this person probably is already a broken person, because it's not okay for a man to abuse his family members. If he becomes abusive, you have to know there's something he or she is dealing with that is causing them to become abusive. So men, women, or whatever, there are women that are very abusive too. And so we need to be mindful of that, but we have to start to help break the cycle. We have to start looking at it as, you know, broken people continuing a cycle of brokenness, and how do we heal?
Thank you all. And at this point, Reverend Pam, if you may have one last question for our doctors, you go ahead and ask it before we wrap up the program.
No, we don't have much time for them. We have 1 minute. I just want to thank both of them. Dr. Kumba, thank you so much, my dear. I really appreciate you. Dr. Tazong, you rock always. And we'll see both of you here next week on the show. You know, please invite your colleagues to dial in. Dr. Kumba, we have a health topic at the end of every month. You know, so I'll keep you abreast. I don't just add it to the forum right now, you know, but on the Sundays, you know, you can zoom in when internet allows. I really, really appreciate you guys on behalf of Africa's Online Media Corporation. Over to you, Nelson.
Thank you very much, Reverend Pam. Now, Dr. Tazon, your last word on pain and pain management.
Pain.
I think we've basically beat this topic to death. It is a common problem. When you have pain, there's a pretty good reason why you have pain. Don't ignore it. Take care of it. See a professional so they do it the right way. Because the goal is to minimize or basically get rid of the pain if possible. Don't ignore it. Don't try to treat it on your own. And just be aware, be sensitive to your body, be responsive to your body. Pain is not a random thing. It's a body's way of saying something is wrong. Do something about it. Thank you.
Okay, Dr. Kumba from Dakar, Senegal, your last word on the topic.
Yes, thank you. Pain is nature's way of saying something is not right somewhere. Don't ignore it. That's just the last warning. Because as you ignore it, as you postpone it, it gets worse. It can lead to things that would not have happened if you had listened to your body earlier. God is wise. He has taught us many things, and one of the things he has taught us is listen to your body, really, and don't ignore the pain.
Thank you so very much. Reverend Pam, your last word.
Oh, my last word. Okay. Well, my last word will be to our two sisters. We need one of you or one of our African women to come up with a thermometer, because we know pain is very subjective. We want that an African to come up with that, a measuring stick for pain that can be globally accepted.
All right. That said, I want to thank all of you for being on the program today, especially Dr. Kumba all the way from Dakar, Senegal. Dr. Tazon, I know you always write in the chat room, and you're always here on the Sundays. Reverend Pam, I know Houston, in spite of all the rain and everything, you're always there. Thank you all so much. Divine Chamakon started off the program at the top of the 4 o'clock hour, and we're closing now to be back next week. Remember, the topic will be domestic violence, especially against the women. Thank you all so much. My name is Asonglefac Nkemleke. Whoa.
Okay. God bless.
That means bye-bye. Thank you.
Nia song.
Yes.
Nia song.
Yes.
Please, I'm going to take an excuse right now because next weekend we have a book launch and I'm not going to be available at all. So please, you excuse me for next week. I would love to be a part of that topic, but I know I'm not going to be there because
no problem.
I'm actively going to be involved in something
else. Put your
moment.
ideas in the chat room. Put your ideas in the chat room. Thank you.
Thank you.
Okay, please.
Thank you, Reverend.
All right. At this time, I can now say bye instead of
bye.
Bye-bye.
Thank you.
Thanks. It's a pleasure.
Have a book launch. I'm not going to be
available. Please announce your book launch.
Excuse me for next week. I would love to be a part of the topic.
All right. Thanks.
Announce it.
Hello.
Yeah, please let her announce her book launch. I forgot to mention that.
Go ahead.
Oh, I'm so sorry. I was almost off the line. So we 15 female African physicians. I'm not going to give the background because it's just going to take a lot of time, but we basically came together and wrote a book about overcoming challenges. And we are basically giving a spiel on life, love, and the practice of medicine. And so far we've gotten raving reviews because it's inspiring a lot of people. It's showing people that you can push past what you perceive as limitations. We are launching the book in Maryland, in the Maryland, DC, Virginia area next weekend at the Maggiano's Little Italy. And we have tickets on sale on Eventbrite. Again, it's called Beyond Challenges. If you can't make it, that is fine. Please support us, but especially we want you to be inspired by this book. It is called Beyond Challenges, and you're going to see a Black female physician on the front cover.
Thank you so much. Thank you so much. Reverend Pan. That is done. And I think at this point, we can now say bye-bye and thank you all so much.
That is fine. Please support us, but especially we want you to be inspired by this book. It is called Beyond Challenges, and you're going to see a Black female physician on the front cover.
Thank you so much. Thank you so much. Reverend Pan. That is done. And I think at this point, we can now say bye-bye and thank you all so much.
My dear sister, I'm trying to shut this thing down. Yeah, how are you? Thank you so much. I appreciate you. No problem. Let me call you back in a minute and let me make sure I've ended the show. Okay, no, stay. Okay, I see what I'm looking for.